Our next speaker, who doesn't need any further introduction, I thank him very much for all the contribution he's made so far to the STS University. It's Dr. Duke Cameron, cardiac surgeon in charge from Johns Hopkins. He's going to give us a talk on genetic linked aneurysm. Duke?
It's intimidating to be on a program where no one needs an introduction. and I'm particularly intimidated to be flanked on this program by Dr. Ehlersdanlos and Dr. Milowitz. If this program is a sandwich, I'm a slice of Spam sitting between two slices of gourmet bread. And all I can do is talk a little bit about patients and what we do for them. Now in Baltimore, we have a slightly different view of history and the development of aneurysms. And as many of you know, Hopkins has had a long-standing interest in Marfan Syndrome. And all of you are familiar with the original description in 1896 by Marfan of a child with very profound skeletal malformations. But many people are not aware that it took nearly 50 years for the aneurysm part of Marfan syndrome to be recognized. And one of the first descriptions of this was by the pediatric cardiologist Helen Taussig at Johns Hopkins. She wrote a case report, it's actually of 2 teenage girls who had the condition of arachnodactyly. It was not called Marfan syndrome in the 40s, but these 2 teenage girls who were related died, both of them, of aortic dissection within a short time of one another. And she wrote that case report, and this is one of the earliest descriptions, I'm not sure it's the earliest, but clearly one of the earliest, that relates the Marfan aneurysm to the arachnodactyly and really completed the triad of the skeletal, ocular, and cardiovascular malformations now that we know characterizes Marfan syndrome. I think it's also important to mention, for those of you who may not be familiar with it, of the so-called Gentech Registry, which exists in the US. It is a data, a blood and tissue registry that was created in 2006 through the support of the NHLBI. And the purpose is to collect information, and as I say, both tissue and blood, and to facilitate research and understanding of patients with a genetic basis of their aortic disease. There are 6 centers originally in the US, and that has been expanded more recently. And they are now tracking over 2,000 patients, hopefully long-term, although their funding for this, unfortunately, is somewhat in jeopardy. But I use this to point out to you that there is great interest in the genetic basis of aortic aneurysms. And I've also used their most recent paper to simply give us a list of the diagnoses that we tend to associate with so-called genetically triggered or genetic related aneurysms. Within that registry of the first 2,000 patients, Marfan syndrome was the most common, the second most common bicuspid aortic valve, and the familial thoracic aortic aneurysm disease, the fourth, actually the third and the fourth. And I'm going to leave it to Dr. Milowitz to talk specifically about that, because that is where I think most of the action is going on right now, and the landscape is changing most quickly. This is not to say that this is the prevalence of these diseases in the general population. Marfan, I think, is overrepresented because it has a very recognizable phenotype. So it tends to be diagnosed with greater ease. So let me talk about a few of those genetically related aneurysms and just try to give you a thumbnail sketch from a clinician's perspective of what these aneurysms mean. Well, if you exclude bicuspid aortic valve, Marfan syndrome is the most common inherited connective tissue disorder, at least we believe it is. They have a peculiar form of aortic dilatation. It's the aortic sinuses, and it's unusual for the distal ascending aorta arch or descending aorta to dilate. It often is dilated distally only because a dissection has occurred. And I too am fascinated by the distinction that John made between these genetically based diseases which tend to affect the ascending aorta and the descending thoracic aortic diseases, which are completely different and probably more of a degenerative nature. And I'm also struck that in the ascending aorta, it's often an aneurysm that leads to a dissection, and in the descending aorta, it's very frequently the other way around. They are really 2 very different disease processes. Rupture and dissection are very rare in Marfan syndrome before the age of 12. So the most common question we often get is, when do you know when to operate in children? Well, we still don't know for sure, but I can tell you that we monitor some fairly large aneurysms in small children because it is rare to see a dissection before the age of 12. The indications that we generally agreed upon would be a root greater than 5 centimeters, growth more than probably a ½ centimeter a year, progressive AI, particularly if you're hoping to preserve the aortic valve with a valve-sparing operation, and then obviously the presence of dissection, either acute or chronic. I'll also mention another aspect of this disease that I've always found fascinating. We are very, very focused on the size of the root and use that as the trigger to operate and prophylactically replace the aorta. Yet, when a dissection occurs in a Marfan aorta, it's usually not in the sinuses. It's usually just above the sinuses, right there. And maybe the sinus diameter is just, again, a surrogate for aortic fragility. But what we're focused on most in the monitoring and measurement is not actually where the bad action happens. I've always found that somewhat fascinating. We know that Marfan syndrome shortens life expectancy by about 1/3. These are based on life expectancy studies that were done, or natural history studies done at Hopkins in the late 60s and early 70s. It's possibly the most misquoted paper in aneurysm history because it actually misquotes the average life expectancy as I think 52 or 42, but actually what they're misquoting is the average age of death of people who died in the cohort. So, in fact, life expectancy is shortened by about 1/3, but it's not actually 32 years, which is it's actually misquoted that way in lots of other studies. The surgical options for Marfan syndrome, classically the ventral operation, replacement of the sinuses and a portion of the ascending aorta. One can also do valve-sparing operations, but we have learned that this disease must be treated, if it's going to be treated with a valve-sparing operation, with a reimplantation operation. They must have annular stabilization. It's not necessary to prophylactically replace the aortic arch. If the aortic arch is not dissected and you're doing a prophylactic operation for the sinuses, it is sufficient to stop before the innominate. The chance of a new dissection or late aneurysm formation of the arch, it's not zero, but it's very small and doesn't warrant the added risk of a prophylactic arch or replacement. Lois Dietz syndrome, many of you are now familiar with, but this was a disease that was only described in 2005. Dr. Eleftheriou showed you the pictures of Hal Dietz and Bart Lois. Hal Dietz is a geneticist and pediatric cardiologist at our institution. Bart Lois was a Belgian geneticist who spent 2.5 years with us. And they saw a number of children in the clinic, fortuitously in a row, who had been sent for an evaluation query Marfan syndrome. And it was the rapid sequence of seeing these children in a row that led them to recognize this was not Marfan syndrome. There were distinct features that were different. They have this hypertelorism that one recognizes, this arterial tortuosity, which is very rare. You really don't see that in Marfan syndrome unless the aorta is dissected. But an undissected aorta, you see tortuosity like this, particularly up into the neck vessels, should make one think of Lois Dietz. And the other remarkably constant feature of this is the bifid uvula. And this can be subtle, such as this, but this is more than 95% of patients have bifid uvula. So you see a strange-looking child with arterial tortuosity and a root aneurysm, which actually is reminiscent of Marfan syndrome, and a bifid uvula. That's your diagnosis is Lois Dietz syndrome, which fortunately can be confirmed with some genetic testing, which I believe Dr. Milowitz will discuss a little later. These aneurysms are just subtly different from Marfan. Often the pulmonary artery is dilated, it has a slightly bluish color, and there's a more abrupt step off from the ascending aorta to the sinuses there that makes it just slightly different from Marfan syndrome. The natural history of Lois Dietz is very, very worrisome and aggressive. Now, this is in the early stages of the description of the disease, and any new disease, when it's reported and described, usually you're looking at the most severely affected phenotype. So the initial description of the disease might have characterized it as maybe a bit more aggressive than the larger population of Lois Dietz. But in these first 90 patients, mean age at first dissection 25. Death occurred in those in 26 patients, a third of them below the age of 18. This would be very unusual for Marfan syndrome, by the way. Life-threatening events in pregnancy. Of the 11 pregnant women in that cohort, 7 of them had a life-threatening complication of either aortic rupture or 7 uterine ruptures. And thoracic aortic dissection or aneurysm, the ascending aorta with dissection, were the most common causes of death. So a very, very worrisome disease. The surgical approach is similar to Marfan syndrome. We do the same operation of aortic root replacement prophylactically, but we do it at an earlier stage when the children's roots are more than 3 centimeters or an adult greater than 4. And they require much more intense imaging and surveillance of the peripheral vasculature because, again, unlike Marfan syndrome, this disease spreads distally into the aortic branches much more aggressively. I'll just mention Turner syndrome as one of those, and we all know, of course, that Turner's syndrome are prone toward aortic root aneurysms, coarctation, bicuspid aortic valve. But what I think many people didn't appreciate until Carolyn Bondi's paper from the NIH pointed out that they do have a greater risk of aortic dissection, and dissection occurs in much smaller aortic diameters than the population at large. There were over 200 patients followed in their cohort, and the 3 patients who suffered dissections all had dissections at an ascending aortic diameter less than 5 centimeters. So this is a group of patients that probably needs a Z-score or a correction for the small body size and a prophylactic intervention at something earlier than the typical 5 centimeter rule. Ehlers-Danlos syndrome, I'll just mention briefly, it actually probably doesn't belong in this talk, even though it's a genetically triggered aortic disease. But the problem, as you know, with Ehlers-Danlos is spontaneous arterial rupture, and that often occurs without an aneurysm. And the surgical treatment of these is so disappointing that it generally has been a reactive and expectant treatment plan that you deal with complications. Even now, if you operate on a true type 4 Ehlers-Danlos, there's almost a 50% chance that you'll end up back in the operating room in 24 hours because of bleeding problems. The distribution of EDS4, of the serious complications seen in the Mayo Clinic series, most of them still were in the thoracic aorta. So in that respect, it fits within this category. Finally, I will leave familial thoracic aortic aneurysms to Dr. Milowitz because she is the world expert. As I say, this field is changing so rapidly that what I read last night, I'm sure, is already out of date. So in summary, advances in the understanding of the genetic underpinnings of aortic disease will lead to substantive progress in the diagnosis, the risk prediction, and potential new therapies, of which I think we are about to hear in a few minutes. Thank you very much.